provider compensation strategies in the rural health clinic setting. As we looked at what we were going to do with this session, as far as topics, we looked at a lot of the questions that we received from providers, and we are getting a lot of questions in the area of compensation. And the compensation questions are, how can we put this together correctly in our RHC? How do we handle things because we can't afford what the big providers are doing? Just a lot of different things that are going on. So with that, this is going to talk about compensation strategies that are very specifically focused towards a rural health clinic setting. And so the agenda will be we'll talk about some of the challenges, some of the opportunities we have. We'll talk about alternative compensation strategies that we are seeing in the market. There's a wide variety of sessions or strategies that are out there. We'll talk about some examples and how those examples may impact reimbursement and help people maybe decide how to strategize as you develop your own methodologies. We'll have a little bit on takeaways, and finally, we'll make sure we have time for some questions and answers that might be specific to you and your organizations. So let's start by talking about the rural health clinic challenges. The challenges that we have in the rural health clinic are the same issues that we see other providers having for challenges. So the same recruitment issues that are being experienced by other rural providers, you need to be competitive in the compensation package. Obviously, you don't get providers coming into your organization and doing that at a cost that is lower than what they would do if they would go elsewhere. We're seeing new compensation methodologies. And these are methodologies and strategies that they're seeing in other facilities. And so now we're having to deal with the potential incentives and things like that that other providers are having provided to them in other areas. We have limited resources being rural providers. That's typically a big piece that we have. And on top of us having limited resources, we have some new challenges that are coming on. We all have increasing costs. You don't have any of the organizations we work with that are seeing a decrease in compensation or decrease in overall costs. If anything, costs continue to grow. And while we may have an RHC program that provides us some opportunities to get enhancements in reimbursement, some of the bigger challenges we have are our other payers. We have other payers out there that have us on fee schedules, and as we look at what's been happening on those fee schedules, there's been a lot of stagnation. A lot of providers that are looking at fee schedules with no change or extremely minimal change from one year to the next. So we've got all those challenges that we're dealing with there. One of the unique challenges we have in an RHC or a rural health clinic is the productivity standard. That's that whole piece of having to have 4,200 visits for a physician FTE, 2,100 visits for a physician assistant or a nurse practitioner. Those obviously aren't things that apply to a non-rural health clinic setting, although productivity is probably still an issue there. They don't actually have the calculation and the limitation on the reimbursement. So when we look at the opportunities, because as a rural health clinic, when we think about this methodology, and I'll say it again a little later, this is usually the best reimbursement model you can find for a rural provider. The times when it may not be the best is if you have some significant productivity issues that are causing you to be hit by the productivity standards. So let's talk about, why is it such a great opportunity? First and foremost, cost-based reimbursement for the rural health clinic services. Now, that's just the services that are considered our rural health clinic. If you're doing something in the hospital as an inpatient, an outpatient, if you're doing some of the chronic care management, telemedicine, those aren't going to be cost-based. But we get a cost-based methodology based on a cost per visit. And there's no cost per visit limit on that cost if you're part of a facility that's less than 50 beds. If we talk providers on the phone today that are less than 50 beds, critical access hospitals, they're going to get a cost-based reimbursement that's oftentimes $125 to, I've seen them over $300 per visit reimbursement that are being picked up. Now, as we talk about that, though, I always like to make sure everybody understands how the real calculation works from a reimbursement perspective, because it's not actually 100% cost. the way that the reimbursement works, because of the way it flows through the cost report, it's more equated to about 80% of your cost and 20% of the charge. Because the coinsurance that's applied on a claim is 20% of the charge on the remittance advice, but when they go through the cost report and they say, okay, we're going to pay you your portion of cost, they take 80% of the cost. They don't take their total cost less the coinsurance that you were able to bill. So in most facilities, if you're a provider-based rural health clinic, your costs oftentimes are significantly higher than your charges. And if you don't get your charges up high enough, you actually get paid a little less than your total cost. So just something to keep in mind there. We also have a few other areas where we have opportunities where we may be able to get some additional reimbursement that's cost-based for RHCs, and that's if you're part of a critical access hospital, and that would be if you have medical directorships. Maybe they're the medical director of the hospital, or you know, a department or whatever. Those costs that are there would be an allowable cost on the hospital component of the cost report. Then we have the emergency room availability costs or the on-call costs. A portion of those costs are going to be allowed also if you have the proper documentation, and Medicare picks that up based off of their overall utilization of those departments that the costs flow into. So let's talk about some of the alternative compensation models. And I've been in this business now for 20-some years, and back to my hospital CFO days, I can tell you, back then, pretty much everybody was on a salary-only methodology. What we're going to talk about today is everything from the salary-only that people still have to some of the more innovative and incentive-based methodologies that might be out there for you to consider. So we're going to talk about salaries only. We're going to talk about gross and net revenue methodologies, production only, salary and production, salary and quality, salary and administrative, salary and call. And then, as you can imagine, there's the last one that is, what if we have all of them? Because we have salary, we have production, we have quality, we have administration, we have call. Ultimately, in your contracts, you should be looking to address all of these to make sure that there's the proper alignment and incentive for the providers to be doing the things that you want them and you need them to be doing in your organization. So, common issues before we get started here. And this is kind of the, when I get a call from a provider that says, hey, we want to look at doing something with our compensation model, the first thing I ask them is, you know, what kind of data do they have? Because that is the core of any of these incentive methodologies. So the first thing we need to know as you're looking at any of these is, what do you have for data? So you have to know your data. And what I mean by this is that before you ever sit down and talk to providers, talk to the physicians and roll any of this out, you need to make sure that you have solid data that as they ask you questions, they're going to feel comfortable with. Because if they find any flaws in the data, any flaws in the information, what they're going to do is it all becomes suspect. And you basically get one shot at this. So oftentimes what I'm looking at is digging through and figuring out what's their ability to figure out what production is. You know, can I figure out what gross revenue is? Can I figure out what my net revenue is? Can I figure out what my work RVUs are? Can the physicians look at it and trust it? Because if you don't have good data there, you're going to be in a lot of trouble. And then making sure it's the right data. Is it relevant just to that provider? Is it just to the right services? You know, is it accurate? Is it auditable? All of those components. So as you look at any of this, that's a good spot to start. Then you got to figure out, if you're going to look at any of these different models, how are you going to approach the conversation? And, you know, it's basically having that conversation with the providers that let them know, here is what we're trying to do. What's the intent of the change? How does this fit into our long-term goals? And when I say ours, I'm talking as individual providers, the facilities, as well as the physicians and the mid-levels that we might be dealing with. And you have to be careful, because every once in a while when I get a provider and I say, what's your intent for the change? And too often it basically comes down to is we're trying to figure out a way to try to pay them less, to keep their compensation down. And that's probably an okay intent if you have providers that aren't producing. But if we really put together our contracts correctly and look at some of these incentive methodologies and documentation methodologies, if they meet what we're trying to do, the providers should end up being more productive. And if the providers are more productive, we may end up with some more expense. But we're also going to have higher volumes in our clinics. We're going to have higher volumes in the rest of our organization. We're going to hopefully have better quality. We're going to have a lot of other things that are in there. So we got to just make sure we all understand what's the intent. And then who's going to have the conversation? Is it the CFO? Is it the CEO? Is it the CEO and the CFO after they've met with the CMO? And the CMO is going to be the one that's going to try to send the message to the others. You got to figure that out on each facility, being very specific to the individual dynamics of the organization. So let's talk about the first model, and that's salary. And this is still an extremely common methodology that we see out there, much more so in small, and when I say small, I'm talking extremely small, rural areas. And it's just the way that things have always been done. And there's some pros and cons to the methodology. The pros are that you can say, hey, you come here and work for me, it's going to be X number of dollars, and that's going to be your compensation. It's a little easier to recruit to versus somebody coming into something that might not be as well known, isn't as clear. I don't know what volume is going to look like. I'm not willing to take risk. There's some of those pieces. From an administration perspective, it's pretty easy to administer. We're going to pay X number of dollars a year. We're going to pay it out, every week, 1/26 of the compensation, and that's what's going to happen. For the most part, probably a little less risk from a start or an anti-kickback perspective. Oftentimes with these, patient satisfaction might be something that could end up being higher, just from the aspect that you're not going to have providers that really have an incentive to be going through faster. They may take more time with the patients, maybe more complete, just a lot of things that go there. This is often used, even in facilities that have looked at doing something different. It's often used in that first year, 2 years, or 3 years of a contract when you're bringing somebody in. Probably most of the time, probably not past the second year. And also, when we're doing transition to other models, this might be the starting point, and then you may take and say, well, next year we're going to pay half of it based off of a salary, and the other half is going to be under this new model we're going to transition to, or we may transition it over 3 years. The con side of it, less incentive to be productive. They don't have that incentive to try to market, build the volumes until such point in time that something starts to fall out as far as the safety net. So that sometimes you don't get the production you want. Less patients, you get less revenue. They still get paid the same. That's a real challenge. And really, when you look at this kind of a model, there's nothing in here that really screams at saying, hey, I want to encourage my providers to be engaged, to be involved, and be an active participant in what we're trying to do. So here's an example. And so when I put this together, all of these numbers are just example numbers. Please don't take and run and try to use these exact numbers in any of your models. You want to make sure you understand your situation. Here's some data from MGMA, one of the survey pieces that we utilize, 2018 survey, which was based off of data from 2017. So it's the latest survey data that's out there. So we have a family practice, and it's got the work RVUs, their encounters, and compensation. So in a straight model, salary model, if we have a provider that we think is going to produce at the median level, we might just say, well, we're going to pay you $237,000 a year, and that's your dollars. If they produce a lot more, they're not going to get paid anymore. If they produce less, they're not going to get paid less. That's just the way the model works. So again, something that's easy to facilitate and administer, but maybe doesn't give us the incentives that we're looking for. So let's move next to the next methodology. And I'm still running into a lot of these: percentage of gross and percentage of net revenues. Basically, they are what they talk about. Percentage of gross is one where it's pretty easy for you to be able to say, hey, I know how many gross charges we have, and it does provide incentives to increase volumes. If I see more patients, I'm going to have more charges coming out of my charge master for my professional components, and as that goes up, I get a percentage of that. As revenues, gross revenues or net revenues increase, the compensation of the provider increases, so hopefully there's more dollars extra coming in than are going out. And in these kind of scenarios, it's that first level of saying, gee, provider, maybe I want to add more clinic visits, or maybe I want to change how much time I have in each one of my clinic visits so that I can get more patients in on a day. The cons, especially if you're looking at percentage of growth, I've ran into this oftentimes where the incentive for management is to hold back pricing increases, because a certain percentage of that price increase goes to the provider. And depending on how the contract is written, when you do a percentage increase in the pricing of services, the provider may end up getting a bigger dollar amount of the increase than what the facility actually gets in the net. So it becomes very difficult to manage getting your prices correct over time, because you're basing on prices and percentage that you're going off. If people get kind of cute on what they're trying to do on strategy of pricing, charges may not reflect the complexity of a patient. And so you might be seeing more complex patients and seeing more of them, but the revenue may or may not be tracking that, and you're not really getting the full incentive with that. The other thing is when we look at net revenues can produce two really big problems. First of all, is how do you calculate net revenues? Because we can figure out gross pretty easy, but to get to net, we're going to have to be able to look at things EOB by EOB to get that explanation of benefits down to the individual claim level, which we might be able to do. But in an RHC, we also have to deal with the fact that we also have lump sum settlements. So we either have paybacks or receivables in the RHC, and how do we get those back to the individual net component of that calculation? It gets to be a real challenge. The other thing that you can run into when you use net revenues is you can get some extremely unintended consequences or behaviors in your clinic. And what I mean by that is all of a sudden, and I've actually had a couple of calls from providers that are dealing with this right now in the last week or so. And what happens is that all of a sudden you have providers that are picking which patients they're going to see, which ones they're not going to see because of the payer source. Because patient A might be worth more than patient B, even if I'm doing the same amount of work. And so you start getting some of that exclusionary and pushing of different payer sources out. And that can be really difficult if you have a new provider come in, because the new providers are going to get stuck with all of the poor payer source, and they're going to have a more difficult time to thrive, because the existing providers at that point in time say, well, here, I'll push some of my base to them. And you can be guaranteed that over time, they're probably not pushing their best payer base. They're pushing some of that that's impacting them maybe negatively. So definitely a real challenge that you can have when you're looking at that methodology. Here is an example of some of the things that we've seen on percentage of gross or net. This is something that comes from MGMA data showing the median out there is paying 33.4% compensation to gross charges. I struggle with that one a little bit because I don't, that has a lot to do with not just the 33.4%, but what kind of conversion factor did you use on setting your gross charges? So this one's a little messier to work with. Definitely not one of my favorites out there. I think it's got a lot of challenges in front of it. So let's move to the next model that we want to talk about, and that's going to be the production-only model. And this one is where you're going to pay them based on the amount of volume they produce. And so typically this is going to be measured on work RVUs. So we use CPT codes. We work with the work RVUs. The pros here are physicians are incentivized to see patients. That's a positive component in there. Growth is measured by the complexity of the patient. And what we mean by that is if the patient's truly more complex, we should have the documentation in the record to drive to a higher weighted CPT code. And with that CPT code comes that work RVU weight, which should also be weighted higher, and it will drive some of that more reimbursement. This is another methodology, again, that helps drive the desire to have more appointments, open up more appointments, shorten the length of the appointments, things like that, to drive that ability to see more patients. Now, some of the cons, And because anytime you put some of these measurements or these incentives out there, you got to look at what might happen. Sometimes you may see quality suffer. I have seen some facilities where production, the provider mindset has gotten too overly focused on production, and it's how many can I get through in a day, not did I get the things done right and all those things. It's how many work RVU points did I earn today. So that can be a challenge. We'll talk about ways to help manage some of that. It can be harder to recruit, especially if you're doing a brand new contract here. Somebody coming in first year, you say, well, we're going to do it all on production. Well, I got ramp up time. I don't know the community. A lot of those issues that we may have to struggle with. Satisfaction may suffer. This might go to that quality, the length of the visits, trying to push too many through. Staffing costs sometimes will be a factor that you'll start to see increase here. And what I mean by that is as you look to move towards production, sometimes you may have your physicians, mid-levels coming back to you and saying, I need a little bit more nursing support. I need some more of this because that's how I can see more patients in a day. That's not all bad as long as it's properly controlled, managed to make sure that what you're seeing in increased volume more than offsets the cost of these other things. But it's something you got to watch. And because production can get out of hand sometimes when you get somebody who gets a little crazy on how much they're going to produce, you may start to see some stark anti-kickback risk depending on how you have your conversion factor set up. What we're going to go to now is we are going to go to talk a little bit more about that production model. And so when we're looking at the production model here, an example, here is using data from the 2018 survey with 2017 data. What we may look at here is, let's say we bring in a provider and they're going to look at the median. And we say, okay, a median provider, we're going to expect 4,800 work RVUs. Our compensation is going to be $50.29 on that work RVU. Now you can see where you could also look at the 25th percentile, the 75th. Actually, when you work with MGMA data, you can get it down to a lot more other breakdowns as far as percentiles. I use an awful lot around the 40th, 50th, or the median, and the 60th when I'm working with providers to say, here's kind of where we're looking at for a potential conversion factor. Now, the biggest piece that you have here when you're starting to look at this is how do you apply that conversion factor? So what I have some providers do is they may say, well, if you're below X number of work RVUs, let's say you're at 4,000 work RVUs, anything up for the first 4,000, I'm going to pay you $45 or $48 or whatever that number is. When you get to 48, then I'll pay you at 50. And then when you get to 5,000, I might bump it up to 52. So that as you do more work RVU production, you're going to give them more incentive, more reward for doing that. Now, when you do those changes in those conversion factors, there's a couple of other things that you look at. Was that 45 to 48, was that on just the first 4,000? And then when I got to 4,800, I'm getting paid at the 50, and that's just for those going forward. And then my next higher number, 52, let's say at 5,000, is that just for those going forward? Or do I apply that work RVU all the way back to the very beginning? And we'll see it both ways. When I see people apply it all the way to the beginning, what they're trying to build in is a little bonus number that it might be $3,000, $4,000, $5,000 when they finally hit that plateau, and it rewards them back to the beginning. So it doesn't feel like, oh, I just finally got here, now I can get the bonus on the future ones. I actually get paid some of that back to the beginning. So that's one thing to look at there as providers are looking at that. I had one physician, they actually wanted some exponential formula, so every work RVU was worth more than the one before that. And I'm like, no, we'd never be able to administer that from that perspective. So this is definitely just a way to look at that. Now, keep in mind this compensation number that I'm showing is salary only. And like I said, I don't want you to use these numbers anyway, but if you were to look at somebody who's contracted, you'd have to build in your benefits and things like that there so that they're getting their proper reward for those components. All right, so let's move now to more of a salary plus production bonus component. This is probably the most common one I see in providers when I'm first converting things over to them. What this provides you is a base salary with the ability to bonus up. So there's kind of some protection on the bottom end. Sometimes it's not a lot of protection, but there's a protection on the bottom end, gives a little bit more security to the provider. So they get incentives. You still get rewarded for complexity. You get more appointments. This one might be a little easier to recruit because it's got that safety net underneath it. They don't feel as much risk. You can get the potential for the the increase in revenue. Cons, same types of things we looked at before. Quality may suffer, stark risk. Administration of the plan can be a little bit more difficult than some of this just straight salaries and things like that. Patient satisfaction could suffer if you get into some issues of somebody trying to be overly productive. All right, so let's talk about what this could look like here. This is going back using a similar scenario. Let's say we have a provider that we decided we were going to pay them at $230,000 a year, and once they hit so many work RVUs at $50, they can actually earn some additional bonus. And so that continues to go up. The things that we look at here are very similar to what we talked about in the production only, in that you have that decision to make. Do you do $50.29 going forward on all work RVUs, or after they get a certain point again, do you bump that even a little higher? So bonuses are only paid out there as you move on. So definitely something to look at. One thing I should have probably even pointed out in the production only model that I've seen is I've seen some where maybe for the first, take them up to, let's say, like the 40th percentile, maybe they're going to get paid at like $40 a work RVU. And then when they get up to the 40th to maybe like the 75th percentile, maybe they get like $65 or $75 per work RVU. So they're really getting paid well on those. So they got kind of underpaid a little bit on the first ones. They get really high pay on the next group. And then once they go beyond the 75th percentile, it drops back down to that 40-ish range. And some people are like, well, why would you do that? That works when you have a nice complement of providers, because it provides incentives to be productive, but it doesn't provide the incentive for somebody to go too far, too much overload. You start wondering about what's just the whole health of that clinic and the practice if you've got a provider that gets too far down the road, working too many hours, too many services, because all they're focused on is the incentive. So there's a couple different ways you can look at doing some of these things. The other thing, when you do a salary plus production bonus that I have seen that I really do like, is maybe in the first year of the contract, it says we're going to pay you $230,000, and that's based on X number of work RVUs. Anything above and beyond that, you get a bonus. However, if you don't produce a certain amount in this next year, in the contract year, your base could actually drop in a subsequent year. And a lot of times what I would look at and see there is, let's say their compensation base is based on 4,000. So they're going to have 4,000 work RVUs, it's $200,000. A lot of times if they would fall more than 15% below that, so let's say if they were less than 3,400 work RVUs, then their next year's base would drop. And then they'd have to earn it back. So there is a protection there, but the protection can go away if you're really a poor performer in future years. So definitely, again, just another way that you may want to look at something in that scenario. Okay, now let's move into another methodology we're seeing out there, salary plus quality bonus. And we want to be careful with that word quality. When we say the word quality, call it a performance bonus, call it whatever you want to do. Quality sometimes gets us in trouble with providers because they're like, well, how do you define quality? And that just gets to be a little messy. So the pros on this side of this thing, of this model that I like, is oftentimes you get providers, or at least a group of the leadership of providers, to provide input on what does this mean? What are we trying to reward? What are the things that we should be trying to do right, that if we do right are good for the patients, good for the facility, all of that. It's not based on volumes. It's based on achieving certain things that should be good for population health in other types of things can definitely lead to some patient satisfaction. Sometimes it'll align with payer incentives. If we have payers that are paying us, if we meet certain criteria, those might be great criteria to build into this kind of a model so that we're incentivizing the providers to do those things so that we get the additional payments that we want to get on there. The con, as I kind of started out with, is defining quality. So sometimes we don't even use that word. You need the provider input. Sometimes it's really good. Sometimes it's hard. Sometimes it's hard to recruit people when you're saying we're going to do quality in here. Right now, a lot of the quality pieces I'm seeing are probably 5 to 10% of reimbursement, but we're seeing a lot of things out there where they're saying in the future we may see 20, 25, 30, 40% compensation in this model, and that's scaring a lot of providers. So, you know, I think if you're on those higher percentages, it could be harder to recruit right now. It can be a little difficult to administer the program because whatever you're going to measure, you got to be able to track. You got to get the staff buy-in, not just the physicians, but you got to get the staff, because sometimes the staff have to help the physicians do things where the physicians are going to get the bonuses. Those can be a little difficult. And if you're not doing this right, you could get into some anti-kickback pieces where you get the comp out of line a little bit. So it all starts with the base, or a base with production, or a production contract. These are just a couple of examples. I've seen hundreds of different examples you can look at. You know, blood pressure might be a quality measure, and the threshold is, you know, patients with blood pressure under 130/80. And if you get 80% of your patients there, you get a $2,500 bonus. And those thresholds are things that you can negotiate and work with your providers, and they'll change over time. BMI, body mass index, you know, less than 24. If 80% of your patients are under 24, you get a $2,500 bonus. And you can see you can change that based on different percentages of compliance with that measure. Medicare annual wellness visits, I see this an awful lot in the facilities that I'm working with that are in ACOs, including rural ACO models, where the more of their Medicare patients that have an annual wellness visit on record, they can get a bonus. Now, when you think about this, this drives a couple things. One, they're getting the work RVUs that go with the annual wellness visit, but an annual wellness visit is a really great way to make sure that you're priming up the patient to get involved in preventative care in the next year, which is a lot of times a lot of additional diagnostic and screening tests in your organization, which also drive reimbursement. So you can kind of see some different numbers here. Most of the models I've been working with maybe have $10,000, $20,000 of compensation that are sitting in there. You don't want this to get too big. I've seen some providers that'll have 8, 10 different measures, and at the end of the day, none of them get actually tracked. It just gets to be too much. So we got to be a little careful with that. So, Amy, are we ready for this polling question?
We are. So the second polling question here is a true or false question. The below examples are examples of salary plus quality bonus.
Good. Yep, they all can be parts of it. Patient satisfaction, I think, is a big piece on that one.
So let's go ahead and stop this one. And since we're right here, let's do polling question number 1, which was actual calculation is not 100% cost, it's 80% cost and 20% charge. Is this true or false? And everyone responded almost true. So good job, guys.
All right. Yep, that is true. All right. Well, let's move on then to the next methodology that we have out there. And the next methodology that we're going to look at, salary plus administrative pay. And what we mean by administrative pay are those extra things that we want them to do that are around administrative kind of work. And what we want to do here by having extra pay set aside here is we want to get engagement. We want to reward this other work. I get people that call me and they say, I can't get my providers to do their medical directorship work. And I'm like, well, how much do you pay them? Well, we don't. We just pay them on production. Well, there's a reason why they're paying attention to production. We have to have the right scenario set up. So rewards that other work, helps build a relationship because you really want them to be involved in those administrative functions because it promotes a stronger relationship between the C-suite and providers. The cons here is you need a detailed contract. You got to make sure you understand what it takes to administer it, because you're going to have to make sure you track the number of hours, because it's usually an hourly basis. You're going to do a little bit of audit. You're going to have to watch. And, clinic time might suffer if you don't have the right pieces around that. And what I mean by that is when I look at this one here, you can see how we're paying so much per hour. I've got a couple different factors, and this is, again, something you'd want to look at what your market is. So let's say it's $140 an hour. Most of the time what you'd want to see in the contract then is, here are the functions that we want you to perform. And then here's how many hours we anticipated it'll take, and we'll pay you X number of dollars an hour up to a certain amount without prior approval. So you don't get into a month and find out that they just made the whole last month administrative and function. Now, when we look at these hourly rates, what we try to do as much as possible is make an hour of their clinic time equal to what it would be administrative time, so that there is an incentive to do one but not the other. We want them to do this very valuable work for us. Next, we get into models with salary, and then we have call. Obviously, this is for emergency room. Small rural providers, oftentimes our RHC providers are taking a good chunk of, if not all, of the emergency room call. So we want to make sure we have a model in there that provides engagement, compensation, incentive for them to do that. And those that are willing to take the call, take some additional call, there are some rewards for that. Again, you're going to have to make sure you have it detailed in your contract. You're going to have to make sure you understand how you're going to administer it. You can create too much incentive and burnout in this one here. And I've seen that sometimes where you get a provider that says, hey, I'll just take all this call. And the call pay, while they're covering your ER and you're really happy about that component, there's too much incentive there, and it comes at the cost of their clinic practice. And so sometimes we need to try to balance that a little bit in the wording and everything else. And we also need to make sure that we're watching kickback pieces. Here again, this is call time, so it's not always face-to-face. A lot of being available, but not having to be doing face-to-face work. Here you can just see some low, medium, high bases or numbers that go with that. Definitely want to look at that by your market. I've seen some where they'll pay a certain dollar amount for the first so many shifts, and then they'll pay maybe a higher amount if you commit to even more than that, because maybe that's how they keep from having to use outside entities that may or may not be more expensive. But you still got to balance that against getting an incentive that comes at the expense of their clinic time. But here, this one's a really good one when you're trying to promote them to be involved in your emergency room setting. And then there's that catch-all one, where you've got a little bit of all of these. And I've got a couple of contracts that I'm working on right now that I would say have all but the call in them. I've had some that have had all of them, but actually, I take that back. I do have one I'm working on that does have the last one too. So, the piece here is when you have individual buckets that you're compensating them, incentivizing them to do, it provides engagement. We get it gives the right incentives to do the right things. Cons is if you're going to get it to work right in the examples I'm going to show you here in a couple seconds, you have to have a detailed contract. It's going to take a little bit of time and effort to administer. You have to make sure you got the right data, and you got to make sure you're not creating too much of the wrong incentives, so you don't get that burnout that could potentially go with that. So let's talk about examples and the impact on reimbursement, and maybe some potential strategies that you might want to consider. So here's a common contract scenario that we may run into. And when we look at this here, we've got 5-day-a-week clinic, 1 weeknight ER call per week, 1 weekend ER per month, doing some mid-level supervision, hospital medical director, and we're going to compensate them $360,000 and $840. Well, the challenge that we run into, if we're not careful, is we get to the end of the year and we're having to figure out the cost reports and how do we allocate our costs? Because it's just all one lump sum. We didn't write in the contract how much we were paying for each individual component. So how much do you allocate to the ER? Because the ER, if I have on call there, a portion of that cost could be allowable. And remember, in the ER, that portion that Medicare sees, I'm going to get 100% of the cost based on Medicare's utilization of that department. If the cost stays in the RHC, I'm going to get 80% of that cost. The other things that we look at is, remember, the RHC from Medicaid, you get a fixed rate on it. So the costs are there. You're not going to get the money there. But if it was in the ER, depending on your state, you know, because the states vary on how they compensate Medicaid critical access hospitals, you could end up getting some of the cost allowed there. So you want to look at your methodology as you think about that. But how would you even allocate that? Would it be an hourly rate? If it doesn't say anything in the contract, do I have to take my total hours, my clinic hours, my call hours, and then do I divide it into it? And do we treat all hours equal, or do we weight them? But then we don't have a basis for weighting. That is a common challenge we run into when we're doing cost report prep. And then how do we hold people accountable with that number? Okay, I get my dollar amount. I'm going to get $360,840, but I don't know how much production I'm supposed to do. I don't know necessarily what I'm expected on my supervision, my medical director responsibilities. What happens if I don't do them? You know, how does all that work? So then we get to what I call a better contract. So a better contract, 5 days a week, you got all those pieces up there, talks about, you know, ER calls, 15 hours per shift. It's the hours the clinic isn't open. The weekend, 61 hours. It's basically 5 o'clock on Friday until Monday morning. PA supervision is going to take 40 hours a week. Hospital medical director, 48 hours a year. The compensation, the base is going to be $236,000. Excuse me. Weekend ER, $58,000. Weeknight ER, $58,000. Weekend ER, $55,000. PA supervision based on 40 hours, we're going to get $5,200. Medical director, 48 hours at $136,240. There's my $360,840. Now I have a basis for making sure that I can allocate things correctly on my cost report. Because without that basis, we're at the risk of Medicare coming in and saying, I don't like the way you did it. I'm going to redo it for you. And you can bet when they redo it for you, you're not going to like the results that you get because it's going to be different than what we would expect. So we've talked about this better contract scenario, but I have a big caution here. I have providers that have done all of this homework on the front end. And then they sit down with legal and they write out the contract. And when they write out the contract says, these are all the responsibilities that we're going to do, and we're going to pay you $360,840. None of the detail is in the contract. Not in the contract, not in an addendum that's referred to in the contract, nowhere. So now when we get to the cost report, and if we ever get to a Medicare audit or something, we are still back at square one. So we've gained nothing, even though we've done all the work on the front end trying to figure out how to document fair market value, make sure it's right, gives all the right incentives. If it's not in the contract at the end of the day, we're in a lot of trouble. So when you look at the better contract scenario, limited challenges because the specifics are in the contract. The more specifics you have in the contract, the easier it is to administer, the easier it is to make sure that you're holding them accountable, they are holding you accountable, there's less room for disagreement. Doesn't mean you won't have any, but less room. Some of the challenges you do have, though, is you tracking hours. You know, do I have my hours for my 48 hours of my medical director? Do I have that documentation to support why I paid them? It helps you, you know, in this scenario, it'll help you document fair market value, but then you also may have to readdress it of what if they don't fulfill those shifts or those things? Will that comp be taken back? I have a provider I'm working with right now where that's basically the way theirs is set up. Their contract says they're going to take so many shifts of ER, and every quarter, if they haven't taken those numbers of shifts, they're basically adjusting their ongoing pay to make sure that they're not overpaying. At the same time, if that person sees more shifts, they're actually making sure that they're compensating them, incentivizing them to take those extra shifts. So, Amy, question number 3.
All right, polling question number 3. Which examples are part of the better contract scenario?
Both A and B. So with that, let's move on to the takeaways and talk a little bit about hopefully what you're going to walk away with today as pieces to help you as you go forward in your contracts. First and foremost, the takeaway number one, you guys do have unique challenges. You do have unique opportunities. This is the best reimbursement model out there if you don't have productivity problems. That's the nice thing about having incentives in your contracts, is you can help drive that productivity if you have a clinic that's struggling. Recruitment can be a challenge, but this favorable reimbursement can at least help us get some of the dollars that we need. The alternative compensation models, for a long time we heard a lot of providers saying, no, the only thing that we can do here is salary only. We can't build incentives, it won't work, and everything else. I'm telling you, we are seeing this in very small providers. You can tiptoe into it, take it cautiously at first, but if you do it right, the providers and the facilities are both seeing this as a win-win opportunity for the organization. I think it's a great way to look at that. Data is key. A lot of the things you heard me talk about were work RVUs. You have to have a methodology in your system to easily print out at the end of every month all the work RVUs. You have to be able to track, how many of your patients are getting annual wellness visits. What are the BMIs? What are the blood pressure numbers? You need to be able to do that. And the nice thing is a lot of the EHRs are getting more sophisticated in their ability to be able to download that and pull it off for you. So when we look at those models, that's where I start, is what does my system already give me? And are any of those things that we should be measuring and helping incentivize through? And then finally, this is my reimbursement hat being put on, because we know we got to spend the dollars, but I want to make sure you get the compensation reimbursement back from Medicare and other payers, as you should, is clarity in that arrangement. The better you do that, the better you strategize, plan that, either internally, working with your cost report preparer, your financial consultant, depending on the skill sets that you have in your organization, making sure that you've put that together so that it's best structured to allow you to capture the dollars and cents that you have coming to you if it's all properly documented. So with that, let's move to the next polling question. Here we go.
All right, so this polling question is going to look a little bit different than we have it on the screen. We were hoping to get a blank answer and get your feedback, but it wants a multiple choice question. So please just select how we can best help you. And if you have any questions or specific ideas that you're looking for and how we can help you, if you're looking to learn more about Eide Bailly, you can always email us.
All right, well, we're waiting for that to finish. Amy, do we have any questions that came in?
Not related. Oh, yes, we do have one. Okay, what happens if we have hired someone as a new physician for the RHC and they do not meet the 4,200 visits? How does that get handled on the cost report?
Oh, perfect. Great question. So first of all, let's talk about a full-time equivalent employee. No provider, knows a big term, almost no provider will ever be a full-time FTE because we carve out time that they're not in the RHC. So this would be time that they're doing inpatient rounds, outpatient rounds, covering the ER, on PTO. If it's a physician, time that they're doing supervision of the mid-level because they're not available to take care of patients. But let's say it's a 1.0 FTE for whatever reason. They're going to take those visits, or the FTE, take it times the 4,200 and say, okay, this provider was expected to see 4,200. They only saw 4,000. Well, when Medicare takes and figures out its cost per visit on the cost report, they're not going to divide it by 4,000, which was your actual number. They're going to divide it by 4,200. So basically, it results in a dilution of your cost per visit. Now, the key to remember, though, is that this is not done physician by physician or by category of provider, meaning it doesn't look at just the physicians and then the physician assistants and then the nurse practitioners. It takes the productivity standard that was calculated for the accumulation of your physicians, your physician assistants, your nurse practitioners, compares it to the total number of visits they did in the aggregate, and then divides it by the larger of the two. What will typically happen is in most practices, physicians will struggle to hit the 4,200 mid-levels will tend to be able to easily exceed the 2100. So the mid-levels help cover the shortfall of the physician. So when I look at facilities that are getting hit by the productivity standards, sometimes what we'll find is it's clinics that are heavily laden with physicians with very few mid-levels. So let's say we have 8 physicians in an RHC and 1 mid-level. The problem might be is that we could fix it if we had 7 physicians and 2 mid-levels. And some of those changes. So there's some strategies you look at in those scenarios. So hopefully that answers that question. Anything else, Amy?
All right. I don't see anything. Oh,
Okay, just a couple things I'd like to add then.
Okay, go ahead.
First of all, remember, you're never too small to do this. I don't care how small your rural health clinic is, how small your facility is. You can always come up with some sort of methodology to build some of these incentives to get the right actions. Everybody does better with incentives and rewards and things like that there. If you have concerns with providers, because a lot of you probably already have a certain model you're using, now you're going to go to the next contract and look to do something different. Don't be afraid to say, you know what, next year we're going to talk about a change in contract, and we're going to tell you what we're going to do in 2 years, but next year we're going to show you throughout the year what would happen to your compensation under this new model. So you basically have like a hold harmless year, but you report the data. And what that allows providers to do is, one, to get comfortable with it. And if they are by chance a provider that should be concerned because they're not producing, they're not doing what they need to do, it gives them time to change their practice, their activities, the way that they run their part of the piece, so that when it finally does come to a point where it's going to hit, they're going to be okay. So I see a lot of facilities that have done the hold harmless for a year. Now, don't do a 5-year hold harmless or anything like that, but a short hold harmless can be very, very beneficial to help everybody get on board together.
Okay. Do we have time for 2 questions that have come in?
You bet.
Okay. First one says, in contracts that include ordinance for quality control, directorships, etc., should total all-in compensation per WRVU be comparable to the MGMA? If you want, on the question bar at the bottom of your screen, if you want to look at this one, it's pretty long.
Nope, I got it.
Okay.
You know what? Once you add quality and you add some of these other components into there, like administrative time, your compensation in total is probably going to look possibly a little higher than the compensation per work RVU if you look on MGMA, because you've added administrative functions. You can't expect a provider to take on administrative functions and have to get the same number of work RVUs to get a compensation number. So you may see some fluctuations from that. That's kind of the art of looking at some of the work RVU components, because if you get into the MGMA data and some of the other data out there, sometimes they will have other factors that they'll show you too, where you can look at call comp and things like that. So I look at that a lot too. MGMA data is a nice benchmark, but remember, they're always benchmarks, and they're kind of tools and guides. They're not 100% black and white.
Awesome. The next one says, how do we allocate provider time if they are working in the RHC and on call in the CAW at the same time?
Well, the piece that I would look at there is, first of all, if they're in the RHC and they're on call for the CAW, any time that you pay them, anything separate that you break out for that call time in the ER while they're in the RHC is a non-allowable expense. Because for it to be an allowable on-call cost, they cannot be on call or providing professional services elsewhere from the ER. And since they're in the RHC, that would be problematic. You will notice in the example that I provided that they would only have weeknights that I'm actually paying them for call. Because in the production model, I would pay them their work RVUs throughout the day, regardless if it's in the clinic or the ER. So none of that's call pay. Then the pay that I do after hours is all call. and then I can keep track of how many hours they were involved.
Awesome. That is all the questions that have come through.
All right. Well, I want to thank everyone for the opportunity to present on this topic. It's an issue that we're seeing more and more questions on. I would say it's something that we're seeing the models changing very quickly. So what we've talked about today in a year may be quite different, but definitely something that I think everybody should look at and see what opportunities they have to improve the compensation model as well as the overall financial performance of the organization.
Awesome. Thank you all so much, and you have a wonderful week.